Welcome to the Interventional Therapies of COPD webinar. Before we begin, as a reminder, at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters, and make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit those through the Q&A box as well. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn it over to Nicole Goldsboro. Please go ahead.
Thank you, Kayla. Hello and welcome everyone to today's webcast on interventional therapies for COPD. As Kayla said, my name is Nicole Goldsboro, National Manager of Lung Disease Programs for the American Lung Association. As Kayla mentioned, if you have any technical difficulties, you can submit them via the Q&A box, and we will get back to you as soon as possible. Likewise, if you have any content-related questions, you can also submit those via the Q&A box. At the end of today's webcast, we will have time reserved for any questions and answers, and we'll get to as many questions as possible. At the end of the presentation today, we will also be reviewing resources from the American Lung Association. Just so you know, these resources can be found on your dashboard, and they include the links. And lastly, we would love to hear feedback on today's presentation. At the end of the webcast, a feedback survey will automatically pop up on your screen. Before you close out of the webcast, please take a few moments to complete the survey. Your feedback is greatly appreciated. Now let's get started and talk a little bit about the American Lung Association. For over 115 years, the American Lung Association has been champion for lung health. Our mission is to save lives by improving lung health and preventing lung disease. From defeating lung cancer to championing for clean air, improving the quality of life for those living with lung disease and their families, and by creating a tobacco-free future, the American Lung Association is a trusted source for lung health education, lung disease research, support, programs, services, and advocacy. And let's talk about what we'll cover in today's presentation. The agenda includes an overview of COPD, treatment options for stable COPD. We'll also dive a little deeper into interventional treatments, which include both surgical and non-surgical. And then we'll go into American Lung Association resources and wrap up with a Q&A. We just want to remind everyone that, as always, feel free to please consult your healthcare provider or personal physician with any questions you have regarding specific medical condition or information from today's recording. And now it is my pleasure to introduce today's speakers. Dr. Mahajan is a medical director of interventional pulmonology and the Complex Airways Disease Program at Innova Fairfax Medical Campus. He is a board certified in interventional pulmonology, pulmonary medicine, critical care medicine, and internal medicine. He has a special interest in management of malignant complex airway diseases, airway complications following lung transplantation, and bronchoscopic lung volume reduction for patients with severe emphysema. I am also joined today by Sue, our patient storyteller, and in a while I'll let Sue introduce herself further. So without further delay, Dr. Bobby, take it away.
Nicole, thank you so much. I really appreciate the opportunity today to talk not only about this very important topic of emphysema, but more than anything, just talk about what the options are moving forward with both non-surgical and medical approaches for treatment of severe emphysema. So I want to say first that as a volunteer spokesman with the American Lung Association and a educational consultant with Pulmonx, this is an unbranded talk, really trying to give people the idea of the educational value of both the physiology of how the body works with emphysema and what the best treatments are at this time. So that being said, let's jump right into the discussion. So I think that what we deal with on a regular basis is trying to understand what emphysema is versus chronic bronchitis versus COPD, which is the blanket term. Really, when we look at our lungs themselves, they are an organ that is used to exchange oxygen with the outside and release carbon dioxide from the inside. And they have a very important job in providing the vital organs with oxygen. Now, when those can get injured, especially from smoking, what we end up seeing is that they can develop different types of pathologies, injuries to the lung that comes from chronic inflammation that is usually a result of smoking. The typical response of smoking is what we call COPD, which is chronic obstructive pulmonary disease. Typically, that's used as a blanket term for two types of subcategories. One is chronic bronchitis, and the other is emphysema. Although they both fall under this COPD umbrella, they're different disease processes. Chronic bronchitis is related to the large airways where excess amounts of mucus are produced, and because of that, they can cause blockages of the airway with mucus that can typically be coughed up by a patient with chronic bronchitis to improve their breathing. But that is a result of injury to the airways itself. Emphysema is a little bit different in the sense that the airways may be injured, but it's more a function of smaller airways. The lungs are honestly just a connection in a network of big to small tubes with air sacs connected to them. When those smaller tubes within the airways get injured, those air sacs get damaged. As a result, there's loss of elasticity of the lungs because the lungs are really just big rubber bands in a lot of ways, which we'll talk about. And as a result, there's overinflation of lung. There's air trapped in the lung that our bodies cannot push out, and as a result, it's harder to breathe. Normally, a normal lung will honestly have really large surface areas because there's millions and billions of small little air sacs that are used to exchange oxygen. And breathing itself is not something we think about on a regular basis, mainly because we do it involuntarily. Our body takes care of it for us. But it looks honestly like a large rubber band. Our lungs will expand and retract, which blows air out. Unfortunately, when there's excess injury from inflammation that comes from smoking, those elastic kind of fibers get destroyed. And as a result, air does go into the lungs, but it doesn't get pushed out all the way. And what we see is gas trapping. And that gas trapping is really the cause of a lot of our shortness of breath. And I'll talk about that in a second as well. So I am going to challenge everyone with a poll first. I'm going to say, first of all, what is the major cause of shortness of breath in emphysema? And I'm going to give you guys a few moments to try and decide and select an answer. If I had the Jeopardy music, I'd play it. All right, almost done. I'll give you a few more seconds. So looking at the results, everyone, it's a good kind of spread, but B is correct. Lung hyperinflation. While oxygen levels are definitely affected along with high carbon dioxide levels, those are very important parts of the kind of the pathophysiology or injury that comes from the lung. But the shortness of breath aspect really does come from the hyperinflation. And I'm going to talk about that a little bit now. Normally, when we breathe, what we end up seeing is that the lungs are able to move as a result of their diaphragm. So what we end up seeing is normally a diaphragm is curved, and that's the organ just below, or the muscle just below the lungs. When we end up contracting our diaphragm in a curved nature, the diaphragm goes down on inhalation, and when we relax our diaphragm, it pushes air out. And this is how our diaphragm moves on a regular basis every time we breathe, thousands of times a day. And as a result, the elasticity of the lungs help aid that movement. The challenge is that when we end up seeing patients who have emphysema and hyperinflation, what we see is, as opposed to the diaphragm being curved, it's actually pushed down and flattened. As a result, instead of moving up and down the way it should, the diaphragm instead is pushed down flat and can move very little. And you can see that on the right side of the image is the hyperinflated lung with emphysema, where it's pushed down, and a normal lung, which is curved. As a result, patients are forced to use other muscles to make up for that flattening of the diaphragm and the lack of movement of the diaphragm for breathing. They use their chest muscles, their neck muscles, their rib cage muscles, and as a result, they feel like they're at the gym all day working to breathe. So patients typically, although they may have oxygen requirements requiring supplemental oxygen when they have emphysema, it's not 100% necessary. A lot of times the shortness of breath comes from the fact that they're unable to move their diaphragm appropriately. And because of this lack of diaphragmatic motion and all of the energy that patients require to breathe, they end up becoming more short of breath. Because they're more short of breath, we see that patients have decreased activity. Even further, because they're reduced activity, patients get deconditioned and as a result are more short of breath. And this cycle continues, that they do even less. They become so deconditioned that they're more susceptible to other medical problems. And that's how we see the spiral of emphysema really getting worse in patients. The next question we say is, well, if this is a result of smoking, how do we know if people actually have emphysema or COPD? There are a number of objective ways of looking at this, whether it be not only the presence of spirometry measurements, emphysema seen on chest x-rays and CT scans, but also a medical history and physical. So symptoms we typically see with emphysema are difficulty walking long distances, difficulty doing their normal activities of daily living, which we call ADLs, or even enhanced activities of daily living. Really what it comes down to is the history of smoking. And history of smoking is an important part of this because of the fact that the lungs over time with chronic inflammation result in damage to the elastic airways, and as a result, hyperinflation, like which we talked about, results in shortness of breath. Spirometry is a way we look at an objective measure of how someone is breathing by seeing how much gas is actually trapped within the lungs. The ability to actually breathe out, which is a factor of the diaphragm function and the elasticity, is damaged. So we see patients unable to breathe out all the air that they breathe in, and that's how another way we look at diagnosis of emphysema. So there's different spectrums when we look at COPD. Okay. Now, some people have emphysema, chronic bronchitis to the point where it does affect them in terms of their daily activities, but it's mild in the sense that someone might have trouble walking up 5 flights of stairs, but they can still do that walking. Otherwise, what we end up seeing is that patients who are considered really severe emphysema are essentially debilitated from it. Their symptoms occur on a daily basis. They have multiple exacerbations or acute worsening of their condition, requiring either new medication treatments like steroids, inhalers, or hospitalizations. we see a drop in their actual FEV1, or how much they're able to blow out in 1 second. And also there's a presence of other comorbidities that can be seen with emphysema, such as lung cancers, heart disease, things of that nature. So although there are a number of symptoms that come from it, there are also a number of objective things that we can look at as physicians to tell someone they have emphysema, or their shortness of breath may be resulted from something else, such as heart disease. So how do we treat emphysema once we know that a patient has it? There are a number of ways we look at the treatments, and all of them, in all honesty, depend on the patient. We look to do two things: reduce symptoms, meaning that patients feel better by reducing, giving them some relief of their shortness of breath. Also, we look to reduce the number of exacerbations, because as we continue to have exacerbations of emphysema, it can get worse and worse over a short amount of time. And as a result, that prevents progression of diseases. By improving symptoms, we see exercise improvement, overall health improvement, and outcomes with survival. Additionally, when we reduce number of exacerbations, again, we reduce the number of hospitalizations or worsening of the inflammatory changes in the lung. And overall, we really do reduce mortality associated with emphysema. When we talk about treating stable emphysema first, we talk about preventative care. First of all, vaccinations, getting all the vaccinations we can for pneumococcal diseases, obviously COVID-19, and anything that may result in an increased risk of having exacerbations or worsening of their emphysema. Smoking cessation is also a very important aspect. Smoking is a disease. It's a nicotine addiction. And breaking that cycle and breaking that continuous inflammatory response in the lungs and injury is essential to prevent disease from continuing to progress. Exercise and physical activity. The more patients exercise and strengthen their pulmonary muscles, the stronger and better they're going to do long term. Avoiding triggers such as getting different types of viral infections, trying to improve exposure to noxious toxins are very important as well. And finally, some patients who are seeing that at least are getting to the point where their emphysema is becoming more of an issue, getting palliative care and hospice involved early if they're to that point where they need more symptom care than preventative care. And that involves a number of different approaches when we look at preventative care and aggressive treatments. First, we talk about one, doing the right thing in terms of breathing techniques and strengthening your breathing muscles. Something we'll talk about shortly is pulmonary rehab, which is aimed to improve the functionality of stable COPD. And what does that do in pulmonary rehab? We look at breathing techniques, meaning that we can do different maneuvers like pursed lip breathing, where we breathe like we're breathing through a straw, and that will keep the airways open. Nutrition counseling, meaning that we're making ourselves as strong as possible and supporting our breathing muscles. Disease-specific self-management education, knowing what some of our triggers are and understanding how the lungs can become exacerbated is very important. Supervised exercise training, that's one of the biggest parts of pulmonary rehabilitation, where we have respiratory therapists or physical therapists having the ability to actually support patients and make sure they're doing exercises correctly and safely. Social emotional support, which is an incredibly important part of not only medical therapy, but behavioral therapy, making sure that there is a support network for patients who are dealing with emphysema. And finally, using energy conservation techniques with not only breathing, but activities, doing things the right way to make sure that we're utilizing all our essential muscles, but not overusing them to the point where we're becoming more short of breath and deconditioned. The other therapy that we've seen that is incredibly helpful, and one of the few things that actually does improve survival with emphysema, is oxygen therapy. Now, when we look at supplemental oxygen therapy, it's very important to understand that, again, as that elasticity of emphysema is lost, also some of those air sacs are lost. And as a result, exchange of oxygen between the body and the atmosphere can get disrupted. That just means that sometimes we need to give the body more oxygen to make up for that loss of the air sacs. By giving more oxygen, we get patients back to where they need to be to provide adequate oxygen into the blood. The most important reason for this is not just to say you have a good number there, but that number and oxygen saturation that we're seeing, we always want above 88 to 89%, is important because that provides oxygen to all the other vital organs in your body, the heart, the kidneys, the brain. Without having an adequate oxygen level because of emphysema, you might not feel so short of breath, but it is causing long-term effects to patients. The other benefit of oxygen therapy, which people might not really understand but are really focused on the number, is that even though they might not feel it, there is improvement in fatigue and shortness of breath. Sleeping is significantly improved because patients are, for a prolonged time during sleep, providing the adequate oxygenation to the rest of the organs. And also what's very important that we don't think about again is the effects that we see on other organs like the heart, the brain, the kidneys. There are risks, don't get me wrong, when we use oxygen therapy, especially that's delivered in a non-natural way. Sometimes people can get dryness within their nose. There can be some tiredness or morning headaches. The other thing is that there's obviously a fire risk, especially with oxygen that's being supplemented, especially if someone is smoking. So we obviously say keep away any flammable light or fire sources, especially when someone is using supplemental oxygen. But as we know, supplemental oxygen can be challenging for patients, not only from remembering to use it, but also it's a hindrance to normal functionality and activity. But we have to realize the risks greatly are fewer than the benefits when it comes to supplemental oxygen. So the ability to function more, be more active is really what we look for with using supplemental oxygen. The other very important aspect is for treating stable COPD is non-invasive ventilation. Non-invasive ventilation is a function that we sometimes use during the day, but very commonly at night. And the point of that is to make sure that we're not retaining too much CO2 when we're breathing. As we breathe out as much CO2 as possible with normal lungs, we're not able to do that very effectively with emphysematous lungs. And as a result, COPD levels go high. That can cause some acidity in the blood, and as a result, it can cause damage to other organs. One of the real benefits we see with combining CPAP or BiPAP with emphysema is that there is a significant improvement in mortality and survival in patients who get treated for their obstructive sleep apnea in addition to having emphysema. So one of the things we recommend always is for patients who are diagnosed with emphysema or COPD is to get a sleep study to see if there is clinical evidence or objective evidence of obstructive sleep apnea. One thing you can also ask, which I tell my patients all the time, is ask your significant other. If you snore, there's probably likelihood you need a sleep study. Not only for their benefit, allowing them to sleep better, but also for your benefit and your survival improvement. The benefits, again, having hypercapnia or high CO2 levels can exacerbate and cause patients to get more sick, requiring oxygen, further oxygen or admissions to the hospital. And also, it's just more comfortable. Patients who are able to use non-invasive ventilation on a regular basis are able to not only sleep better, be more rested, and their lungs and muscles are much more prepared for the day ahead of them. One of the risks or difficulties is some people don't tolerate the mask very well. There are signs of anxiety, especially kind of a claustrophobic feeling and some mucosal dryness. But again, we know that the risks are greater than are much higher compared to other utility or other approaches. And the benefits of non-invasive ventilation are definitely greater than the risks. And then finally, the last thing I want to come back to, which is used for both stable and more progressive emphysema or COPD, are medications. One of the hallmarks and staples of treating patients who have emphysema are bronchodilators, which are some of the inhalers we use, combination medications like the different inhalers that combine short-acting and long-acting medication, anti-inflammatory medications like prednisone or steroids, and antibiotics, especially for patients who have exacerbations. These are essential medications, mostly to reduce the amount of hyperinflation and inflammation we see in patients with emphysema. Unfortunately, over time, some of these medications become less effective, especially as emphysema progresses. But still, no matter what we do, we recommend the use of these on a regular basis, even if patients don't feel better when they're using them immediately. And after following that, the initial kind of presentation with emphysema, I want to hand it over to Sue regarding some of her experiences with emphysema and dealing with it on a regular basis.
Thank you, Dr. Mahajan. Sue, are you able to join us on camera? Oh, thank you. Sue, thank you again for joining us today and your willingness to share your story. I was hoping that you could share with the audience a little bit about where you're from and any interests or any hobbies that you enjoy.
Hi, yes, I'm in Northeast Ohio. I love being outdoors. We have had animals here most of our lives and love to be outdoors and messing with them. We've had horses and goats and ducks and dogs and cats, and we've kind of weaned them out. My kids have grown and are gone, so I'm kind of on my own here. Just trying to enjoy the weather outside right now. I try to get out as much as I can, cutting grass and stuff like that.
Great. Thank you so much. And can you share a little bit with the audience about being diagnosed with COPD?
Yeah, back quite a long time ago, my brother had mentioned the valves. I was struggling to breathe. I find doing everyday things much harder. And it got to a point that I wasn't able to do a lot of the things that I enjoyed. And as time went by, it progressively got worse and worse and worse.
Thank you. And we'll switch it back to Dr. Mahajan, who will continue with our presentation. Sue, and then in a little while, we'll hear more about your story.
Okay, perfect. Sue, if you, just to let you know, I'm from Northwest Ohio, so we already have that connection going.
Okay, then you don't know about the snow.
Oh, yeah, I'm all for it. I know it. All right, I'm going to go back to one question as well. And before we get into this, the next poll question is going to talk about a few things. One, what are the main risks for surgery for emphysema? And the first option is high risk of complications and high morbidity, meaning there's risk associated with it. Lack of innovation, meaning we haven't moved very far forward over the last few decades, or there are no risks associated with surgery for emphysema. And I'll give you a minute or so to answer that one before I jump in with the answers. And again, if I had Jeopardy music, I would use it. Another couple seconds and we'll get going. All right, time is up. And again, a very good approach and a very knowledgeable group in terms of what the options are and what the risks and benefits are. So pushing that over to the group and seeing that most of you are, again, correct, almost 80% of you in terms of the risk of complications is high morbidity associated with surgery. There has been quite a bit of innovation, which we'll talk about shortly. And then finally, there are no risks. Well, in some patients, the risk is very low. But again, with any surgery, we end up running into risks. So I will tell you that my approach and my excitement for the topic regarding actual interventional, minimally invasive treatments for severe emphysema is really one of my passions and what's really exciting about this talk and where we're going with regards to COPD and emphysema treatments. And I think that what we have seen over the last 4 to 5 years in the United States and will continue to see over the next few decades is the incredible growth and development of options for patients and the ability to help patients dramatically with minimally invasive approaches. So first, what we're going to look at is how do we approach therapeutic interventions for patients with severe emphysema. We look at benefit and selective patients with COPD, meaning that they are looking with places that are really having a high volume of cases. And then secondly, we look at if from a surgical standpoint, what the benefits and risk of lung volume reduction surgery and lung transplant are before we talk about some of the less invasive approaches. So interventional therapies, especially lung volume reduction surgery. When we talk about lung volume reduction surgery, it's an incredibly effective approach, but it does have significant risks and has been around for a long time, in all honesty. If we go back to the physiology we had discussed before, meaning that your diaphragm, which is supposed to be curved, is pushed down by emphysema because of overinflation and destroyed lung, what we end up seeing with lung volume reduction surgery is that patients who have really destroyed parts of the lung surgically are taken to the operating room and part of that overinflated lung is removed. When that overinflated lung is removed, there's less space that's taken up by that lung. And as a result, the diaphragm moves from more flat to a little more curved. And as a result, can move more effectively. Okay. And this is one of the ways we've looked at over the last few decades. Is this doable and does it help patients? The challenge we look at is that what is the group of patients who will be most benefited from this approach? And what we've seen in terms of approaches and studies and data is that patients who have upper lobe predominant disease, meaning most of the destruction is seen in the upper part of their lungs, and they have low functionality, is that group. Also, they have to have very few other medical problems, comorbidities like heart disease, severe diabetes, things of that nature. And by removing that lung, if patients are able to tolerate that, they're able to do very well and improve their functionality. The only challenge we run into is finding patients who have only upper lobe predominant disease, aren't very functional, but have a very few other medical problems can be very challenging in terms of trying to find a patient that's really going to do well. So does it improve functional capacity? It improves the ability to be active. It improves the capacity of the lung. And again, it improves overall quality of patients. And more importantly, it improves the functionality of the diaphragm, which is what we really look at with regards to improvement of breathing. What we looked at before when we talked, it's not so much the oxygen levels, it's the ability for your diaphragm to move up and down, which is being restricted with emphysema. Removing some of that lung, which isn't working well in the first place, actually allows that diaphragm to do well. The challenge is that there's a number of complications and risks associated with this surgery. Some are air leaks, meaning the lung doesn't heal as well as it should because it's damaged in the first place. The need for being intubated afterwards, pneumonias, blood clots, and there's a mortality up to 7% in these kind of surgeries, which is, again, considered an elective surgery. So in those situations, putting someone through this or finding someone who's going to be very healthy enough to tolerate it, but sick enough to need it, can be challenging. The second option, what we look at that's more surgical approach is interventional therapies that are lung transplantation. Now, just like lung volume reduction surgery, it's a very involved approach, meaning that it's complete transplant of the lung. You're taking your lung, one or two of them out, and putting new lungs in. In a lot of ways, we look at this as a last option for treatment, meaning that there are no medications, there are no minimally invasive procedures that are going to help. The only option really is to remove the lungs. The challenge is that this is often associated with exchanging one disease of emphysema for a new disease of lung transplantation that comes with a number of new medications, risks like infections, rejection, or injuries to the lung. So what we look at is that we do consider patients for lung transplant. The only challenge is that patients who are very sick have to be also well enough to tolerate the therapies and the surgery, just like lung volume reduction. And unfortunately, life expectancy after 24 to 36 months can be difficult, meaning at 5 years, there's only a 50% survival in lung transplantation. So again, it is an option. It just isn't always the best option or the first options for individuals. So again, improvement of qualities of life, but again, there's a number of risks. And the one we really focus on is the exchange of one disease from another. But if it's necessary, it can be very helpful. We just always want to look at everything else prior to moving in that direction. So the last poll question I'm going to ask you is, what are the minimally invasive therapies for severe emphysema with regards to procedures. And I'm going to give you one more minute to look at these, and then we'll talk about them even further. All right, about 15 more seconds. All right, I'm going to look at results. Again, a very good spread. Looking at these results, we see endobronchial valves by about 65–66% of patients participants. Inhaler therapy, what we call a minimally invasive therapy, would actually consider that a non-invasive therapy because no procedure is being performed. And appropriately, lung transplantation is in no way minimally invasive for severe emphysema. So next, I really want to talk about and be as descriptive as possible about endobronchial valves. And again, this is one of the things that really has changed our entire approach to how we treat severe emphysema. So I'll tell you that when I was a resident in my residency over 18 years ago, I gave a talk about endobronchial valves, about the fact that they're just around the corner, 1 or 2 years away, and we'll be able to treat patients with COPD. That was in 2009. Now here we are, even longer before than we expected, and only recently have endobronchial valves come out, mainly because we want to make sure they were most effective as possible, as safe as possible, and we knew what patients were the best, what we call capabilities in improving from these, rather than putting these in patients that weren't going to benefit. And what we've seen is that patients who have severe emphysema with significant air trapping and that are unable to benefit from traditional medical therapies are patients we should consider for endobronchial valves. And they're an FDA-approved treatment that has really revolutionized how we treat patients with emphysema. And they are non-surgical, meaning there's no cutting involved. They are small valves about the size of my fingernail that are placed into the airways of diseased lobes that causes them to honestly deflate without having to remove that part of the lung. As a result, you're getting the same effect we see with a lung volume reduction surgery, that we're taking that lung out of functionality, deflating it, and the diaphragm, again, goes from more flat in emphysema to more curved. And as a result, patients are able to breathe better. It's done by bronchoscopy. Patients are completely asleep during the procedure, and honestly, they feel improvement when they wake up usually. The approach to this is saying that we want to make sure that patients are able to benefit from this. And there's a few factors we look at. First, we want to make sure they have severe emphysema. This is still a procedure, and we're still putting a foreign body into the airway. And as a result, because patients are getting a foreign body and we're putting them in a procedure, we want to make sure that they're going to benefit. So not only do we look at patients with severe emphysema, we want them to be at least 22 years old. And honestly, there's no upper limit to age therapy. We have treated patients 85, 87, who are all very good and functional in terms of their health, but again, are debilitated by their emphysema. We look at a few things. Obviously, we want to make sure that patients have adequate lung function, but we have target lobes, meaning one lobe that we're going to deflate and put the valves in that is pretty significantly destroyed and not functional as the other lobes. We also want to make sure that that lobe that we're going to treat has significant hyperinflation. The lungs are separated into different lobes. On the left side, there are two lobes, a top lobe, an upper lobe, and a lower lobe. On the right side, there's an upper lobe, a middle lobe, and a lower lobe. Now, these typically are independent of each other, meaning that they're separated from each other. But sometimes there can be small connections between the lobes that are microscopic. And as a result, If we block off one lobe, if there is no longer air being able to go into that lobe, because it's a one-way valve, it allows air to come out of the actual lobe, but does not let air to go into the lobe, causing it to deflate. If there are connections in a different lobe, as a result, we end up seeing that air still fills the lobe and it doesn't get the deflation we want. So we want to make sure that those patients are good candidates for it. And the way we test that is to look if the lobes are separated on a specific scoring system and on a CT scan. There are two valves that are approved in the United States. One is the Zephyr valve made by Pulmonx, and another is a spiration valve approved by Olympus. The interesting part of this is that these valves have been available for quite some time in Europe, but right now, after rigorous investigation, quality and safety testing, they're finally have been available after FDA approval from 2019 here in the United States. Looking at these valves, what we end up seeing is they're incredibly small. What we end up seeing is that they are put in bronchoscopically, which honestly is a camera that I use, which is about this long and about the width of my pinky, and is extremely flexible. So we're able to go down into the lungs, do the appropriate testing to make sure the lobes are a good option for treatment, and then slowly deploy these valves into the airway. They're one-way valves that hold in the airway, meaning they allow air to come out of that lobe that we're treating, but they block air from going into that lung. And as a result, that part of the lung deflates. By deflating, the diaphragm is able to move up and patients are able to breathe easier. These are completely reversible valves, meaning they can be removed if a patient isn't tolerating them, which is rare. But again, we have the ability to say, well, if a patient isn't doing well or they're not getting the improvement, we can remove those valves, which is very different, obviously, from lung transplantation or lung volume reduction surgery, where parts of the lung are obviously removed. I will tell you that we have seen significant stories, dramatic improvements in patients, but I know that Sue is going to talk about as well. But some of the patients we've seen have, typically been able to do very little functionality, even short of breath, putting on makeup, taking a shower. I typically will ask a patient, what the main thing you want to do if you didn't have emphysema? One of the options has been swimming. And we've had patients go back to swimming after decades of not being able to because of shortness of breath. And that's where the benefits we've seen, not necessarily just from the numbers. More importantly to us and to myself is how much more functional is a patient because of the valves that we've placed. This is an example that we look at. And again, I don't want to be too technical about this, but this is a chest x-ray of a patient we performed valves on. This is the right lung. This is the left lung. And you see the diaphragm here. And overall, this is the right diaphragm and the left side of the diaphragm. You see the left side is extremely flat. It's pushed down all the way because this lung is hyperinflated. We placed valves in the left upper lobe. This part is that valve kind of deflated and smushed down. And you see how much more effective and rounded the diaphragm is. And as a result, this patient went from feeling short of breath when they're doing their normal activities of daily living, like getting dressed, showering, to feeling incredibly well, doing all his activities, and honestly getting back to some of the sports he had been playing before. What do we talk about in terms of the benefits? Again, we talk about improved breathing, better lung function, but most importantly to me is improved quality of life and ability to do more exercise. Patients recover very quickly because of the fact that they don't have a surgical scar, have had to go under surgery to recuperate from that. There's shorter hospital stays than lung transplant and lung volume reduction. Typically, we'll keep patients in the hospital for anywhere from 1 day to 3 days, mainly because of the main risk we run into are pneumothoraces, meaning the lungs will actually get a small tear in them after we put them in, which we fix with a small tube and then typically allow it to heal over a week or so before taking out the tube. But again, in a lot of ways, we are trying to emulate everything we do surgically, but doing it in a less invasive manner through valves. Next, I'm going to actually hand it back over to Sue to talk about her experience with valves as well.
Thank you, Dr. Mahajan. Sue, you spoke a little bit earlier about your COP journey, and I just have a couple questions for you related to your experience with endobronchial valves. So can you let us know a little bit more about how you learned about them?
Back when I first heard about it, my brother told me about it. This goes back quite a ways. And at the time, there wasn't much information online. My doctors didn't know much about it. And they kind of just decided that, you know, it wasn't worth pursuing at that time. But I'm pretty persistent, and I really wanted to try to improve my life, because I felt like it was getting to a point that I was missing out on doing a lot of things that I enjoyed. So I did pursue it, and I did go through all the tests and that were required, and I got down to the very end of it, and then they said I was not qualified for it, possibility of tears. And so, of course, I was heartbroken. But again, my persistence, I continued to try to find out as much as I could about it. My brother, who is in Florida, also has COPD. They actually did the valves for him down in Florida. So I actually got a hold of his doctor, and they checked my file that I would be a candidate. So I went down to Florida to have it done. Came back home. I was doing quite well. I was in the hospital for 3 days. Came back home, was doing well, but we drove back from Florida all at one time. We didn't stop, and I'll tell you what, that just really took a lot out of me. And then the weather was bad here, and I fell really hard. And after all that, it just seemed like I got worse and worse, and to a point that I ended up calling the doctors and going in, and here I had also developed pneumonia. So they elected to remove the valves. So we did. We set it up and went in, had the valves removed, and the recovery from that took me quite a long time. But again, with my persistence, I wanted to see if we could reinstall it, and my doctor was willing to give it a try. Now, this was up in Cleveland, back home in Cleveland. They were the ones that removed it, and the doctor felt that I would be a candidate to reinstall. So we did go through the procedure. I had it done at the end of November. And at that point, I was on oxygen most of the time. To even just get up to go to the bathroom or take a shower or cooking, it just was a project. It was really, really quite terrible, because I felt like I wasn't living at all. I was just basically stationary. And as the doctor said, you end up doing less and less and less. And I felt like I was just losing it. But anyhow, we did have the valves reinstalled, and 3 days again in the hospital, and things have been getting better and better. And now I'm able to take a shower with no problem, make dinners and no problem. I'm actually going outside and doing chores that I haven't done in like forever. I put a garden in, I planted hanging pots, and working with my dogs, trying to get them leash trained, because before I didn't have the energy to spend time with them. So it's been quite a great move for me. I feel improvement. There are days that I struggle. If it's real humid, I stay indoors. I don't go out. I don't walk marathons or anything like that, but I am able to get around it and do things that I felt before I would not. My boyfriend has a motorhome, and before there was no way that I could go. Just getting in and out of the camper would have been a project. But now we're ready to hit the road and, start visiting and seeing things that we haven't been able to. And again, the valves really helped me quite a bit. So at this point, knock on wood, I'm a candidate to tell you that if there's a chance that you can get them, to definitely get them. Oh, I also, by the way, when I did have them reinstalled, I did take the physical therapy, the pulmonary therapy, and I would strongly recommend that, because that kind of got me going and making me feel better. And then now I watch my steps. It's kind of pushed me to get going and get active again. And I've joined the local Y, because they have all the equipment and a pool. And I'm not doing much there right now because I'm enjoying the summer, trying to get outside and do as much as I can outdoors. But I do watch my my steps, and I feel like I'm doing a lot more as far as trying to do things that I would not have been able to do or even try to do. Exercising, I joined Silver Sneakers. They have classes right online that you can join. Even some of them are 15 minutes, but it's enough to get me going. And before, I wouldn't even have tried. I'm trying to get myself back in condition where I'm able to do a lot more. I'm very hopeful.
Thank you, Sue. I really appreciate you sharing that. I'm so glad to hear of all the different things that you're able to experience now that you're feeling better. Before we go right into the Q&A, I just wanted to share a few resources from the American Lung Association. And as a reminder, on your dashboard, you can also find the links. If anyone's interested, Sue did help share her story in a blog called Treating Severe COPD with EBVs, as well as we have different resources that are available. So I encourage anyone on today's call to check them out. And now we'll go into the Q&A or the questions. As a reminder, if you do have any questions for either Sue or Dr. Mahajan, please feel free to enter those into the Q&A chat box, and we will get to them. So let's just take a look and see if there's any questions. So, right, it looks like some are coming in. The first question for you, Dr. Mahajan, how many valves can be placed at a time and how long do they last?
So no, that's a great question. And honestly, there's not a limited number of valves that can be placed. Typically, it depends on someone's anatomy of the lobe we're treating. So, in the number of years I've been doing these, the least number of valves in a lobe I've put is 2, but in some of the lobes, especially the lower lobes of the lungs, there's a number of airways we need to treat, and I've placed up to 9 in those valves, in those airways, which is, standard is anywhere between 2 and 10. So the number is just dependent on anatomy. The second question is how long do they last? These are meant to stay in, meaning that they're made of nitinol and silicone, which are essentially very resilient and conforming materials. So once we place the valves, there's a good chance that we'll never have to do anything with them again or replace them. Sometimes your airway will respond to those valves, making scar tissue or may stretch because of them. Typically, in those situations, we might have to replace the valve, a couple of years later. But again, they're meant to stay in and they're meant to be able to last for, years on end without taking them out. I have patients who I've had valves put in some of the initial trials in 2005, came back to me to treat another lobe in 2020. The valves they'd originally put in 2005 looked fine.
Okay, thank you. And this is regarding a lung transplant. With a lung transplant, the life expectancy afterwards is around 5 years. How do valves affect your life expectancy?
So again, if you had to answer that question right now, you'd be publishing in the New England Journal. But right now, that data is still being collected. In Europe, they have a much longer story and history of valves because they've been doing them since 2009, 2010. Only recently, in the last year or so, has there been some early data showing that there may be improvement in survival associated with valves. And the big part of that is that patients are able to be more active, exercise more, and get into better health because of had the valves put in. So the data in terms of large sets are still coming out. One of the registries we are part of that collects this information looks at that in the future, but we are starting to see very good signs that survival is improved with endobronchial valves. Again, mostly because patients are just overall healthier due to more exercise and activity.
Great, thank you. And another question, what would disqualify you as a candidate for valves?
Yeah, so there's a couple things that would disqualify you. The first thing are obviously just significant comorbidities, meaning that patients who are have too difficult of heart function to tolerate the procedure, unable to have a bronchoscopy performed because of the anesthesia. In patients who are healthy enough to get valves but don't qualify for them, the most common thing is that, the fissures or the separation between the different lobes within the lung are not complete, meaning they're the communications between those different lobes. In that sense, even if we put the valves in, we wouldn't get the deflation we're looking for. There are ongoing studies that are looking at fixing that, meaning closing off those communications and then placing valves. So hopefully that kind of exclusion will be remedied in the next couple of years. And then the last thing that we look at is overall, when we look at a patient with valves, again, 4 possible valves, we want to make sure we're improving them. We're making them feel better. The last thing we want to do is make their quality of life worse or put them at higher risk for complications after the valves. So when, again, when Sue is, getting told initially she isn't a good candidate, it's mostly because doctors want to make sure we're not putting someone at risk. That also depends on the center, meaning how experienced they are. But more than anything, it really comes down to, can we improve you as opposed to putting you at more risk by putting you through this procedure?
Great, thank you. And we do have a lot of additional questions as well as comments. I think we can maybe get to one more. And a question, once the valves are in, is additional oxygen still necessary?
So again, these are very good questions. So we're just putting together some of our data of looking at patients who have been on oxygen and then get endobronchial valves and what the degree of oxygen requirement is afterwards. So far, our data has shown it's about the same. It doesn't change it significantly. Do some patients go from being on 3 liters or 4 liters down to 2 liters? Yes, sometimes they do. And most of that is because the amount of destroyed lung that we close off, because it's non-functional, the blood and the oxygen or the air might be shunted to different, more healthy parts of the lung. But we don't talk to our patients about getting off oxygen on a regular basis, but because the really goal is to improve functionality by diaphragmatic motion. So if it happens, it's great. And it does happen on a number of occasions. But typically we tell our patients to anticipate staying on oxygen, but being able to do significantly more on the same level of oxygen they're currently on.
Thank you. And now we're about ready to close out. But before we all close out together, I wanted to thank both of our presenters, Sue and Dr. Mahajan. Thank you so much for taking the time to join us today and share your experience as well as your expertise. For everyone on today's webcast, I just wanted to share a quick reminder that we would love to have your feedback at the conclusion of today's webcast. As a quick reminder, you will have a survey pop up. It's a quick 6 questions, and we would just love to hear back from you. Also, those who did ask a question, however, we were not able to get to it, we will forward your information to our lung helpline, and someone will follow up with you with a response as well. Again, on behalf of the American Lung Association, thank you so much to our speakers and for everyone joining us today. Thank you and take care.
Thank you again. Thanks for the opportunity. It really is enjoyable.